Welcome. Today we'll be going over Chapter 39, Hazardous Materials, Multiple Casualty Incidents, and Incident Management. So here is a description from the U.S. Department of Transportation on hazardous materials. It is any substance or material in a form which poses an unreasonable risk to health, safety, and property when transported in commerce. There are 5 levels of training: first responder awareness, first responder operations, hazardous materials technician, hazardous materials specialist, and on-scene incident commander. So responsibilities of the EMT to recognize a hazmat incident. This is an incident involving common carriers, trucking, terminals, chemical plants, or places where chemicals are used. Delivery trucks, agriculture and garden centers, railways, and laboratories. All patients leaving the site should be considered contaminated until proven otherwise. So identifying this, our state statute requires that we have binoculars on our truck. We should be able to remain at a safe distance to identify any placards or anything that are on these vehicles. And then controlling the scene and requesting appropriate resources. So if we roll up on a semi-truck accident and we notice that there's a potential for a hazardous material incident, we need to consider that a hazardous material incident until it is proven not to be. So we need to make note of any placards, try to use your emergency response guide to identify that, and push that information up to the fire department or whoever that responsible agency is going to be in your area. So control the scene, establish a danger zone. So the hot zone is the area of contamination or danger. A warm zone is where we're going to have our decontamination corridor. And then a safe zone, also called the cold zone, where equipment and emergency rescuers are staged. It's also where we'll be able to have kind of a triage area right there between the warm zone and cold zone. Identify the substance. You must make an attempt to assess the material and severity. Again, using your emergency response guide and pushing that information to who it needs to be going to. So you can use binoculars to safely identify any signs, labels, placards from a distance. There are invoices, bills of lading in trucks and shipping manifests for trains that will list all the materials that they have on whatever mode of transportation you're dealing with. But again, if this has not been established to be a safe zone, we may not be going in immediately, to the cab of the truck where that bill of lading is, for example. In plants, there should be a review for the safety data sheets. That should be in a location. It's not always right where the material is, so we may be able to get to that. And then you can interview workers or others leaving the hot zone. Again, they're considered contaminated, so we don't want to touch them or do anything until they're decontaminated properly. Get expert advice about the next actions. You can get that through the Emergency Response Guidebook. There's some other books out there. The Chemtrek is pretty good. Chemtel Incorporated is another resource. A current list of state and federal radiation authorities, regional poison control centers. For the Poison Control Center, be sure to leave thorough information about the scene, callback, container, conditions, location, quantity, and injuries and exposures. Now, these are renewed every 4 years, so we should have 2024 ERGs. So rehabilitation operations is located in the cold zone, protected from the weather, large enough to accommodate multiple rescue crews, easily accessible to EMS units, free from exhaust fumes, and somewhere that allows for rapid re-entry to the emergency operation. Care of injured and contaminated patients. We're going to decontaminate in the warm zone and treat in the cold zone. Field decontaminated patients are not completely clean. A lot of times this is done with like the jump line or the red line from a fire hose, It may be done with some kind of soap or agent that a hazmat team has, but they're not going to be completely clean. Personal protective equipment or clothing is needed to prevent secondary contamination of rescuers. So this may be a case in EMS where we're using our, Tyvek suits that we've got in our PPE sets on the truck. Protect vehicles from contamination. So we need to get the patient as clean as possible, and once the patient's dropped off, we need to make sure that that is thoroughly decontaminated. Consider used equipment as disposable. Structural firefighting clothing is not designed or recommended for use when working in hazardous material environments. That does have the capability of absorbing a lot of stuff. There are 4 types of patients: uninjured and not contaminated, injured and not contaminated, uninjured and contaminated, injured and contaminated. Take precautions appropriate to the substance as listed in the emergency response guidebook and follow those first aid measures. Manage the patient's critical needs, so manage the ABCs. If treatment calls for irrigation with water, remember that water only dilutes most substances and does not neutralize them. After treating the patient, decontaminate yourself. Your clothing may need disposal. You may have to throw that away. Some phases of decontamination. We have gross decontamination, which is the removal or chemical alteration of the majority of contaminant, and secondary decontamination, so residual product contamination, and it's more thorough. Some mechanisms for decontamination. We have emulsification, chemical reaction, disinfection, dilution, absorption or adsorption, removal, and disposal. The objectives of decontamination procedures determine the appropriate level of protective equipment based on the materials and associated hazards. Properly wear and operate in PPE. Establish operating time log. Set up and operate the decontamination line. Prioritize the decontamination of patients according to a triage system. So most of the time in this case, we're going to be working closely with the fire department, who will be doing most of the decontamination. We may be there to assist in triaging the patients and seeing which ones need to be decontaminated first so that we can evaluate them once they're decontaminated. Performing triage in PPE, you must be able to communicate while you're in PPE. So basic list of equipment: buckets, brushes, decontamination solution, and decontamination tubs. You will need a dedicated water supply, tarps or plastic sheeting, a containment vessel for any water runoff, a pump to transfer wastewater from decontamination tubs to a containment vessel, an A-frame ladder may be needed, and appropriate level PPE for responders performing decontamination. Decontamination for patients wearing PPE. We need to rinse, starting at the head and working down. Scrub the suit with a brush, again starting at the head and working down. Rinse again, and assist the responder in removing PPE. Contain any runoff of hazardous wastewater. So this is if we were to decontaminate, say we've got a firefighter that's been in a level A suit and they need to come out for rehab, or maybe they start feeling ill and we need to get them out and decontaminate them. That's what we're talking about. Decontamination for patients not wearing PPE. The first consideration is for responder safety. Use public address system to direct ambulatory patient to the decontamination line. If they're ambulatory, especially if this is a multiple patient scene, we need to have them ambulate to where they need to be decontaminated. The patients need to remove their clothes and any contact lenses. Double bag the clothing. They should receive a 2 to 5 minute water rinse starting at the head and working down. And provide patient cover for modesty. Multiple casualty incidents. Multiple casualty incidents, or MCIs, may range from small to large. In this bus crash, all passengers were triaged and 44 patients were transported to area hospitals. So you should know if you have a local disaster plan. These are normally written to address events that are conceivable for a particular location. Well publicized, that may be just within your first responder community where you're working. They need to be realistic and they need to be rehearsed. NIMS, or the National Incident Management System, is centered on concepts for preparing for, responding to, and recovering from major incidents. Incident Command provides clear management framework for all types of large-scale incidents. So under the command structure, we have operations, plannings, logistics, finance, and then it can be a single incident or unified. So a single command is the fire department alone or the ambulance alone is in command of the scene. A unified command is where we have police, fire, and EMS all working in a command center together. Command functions. Incident command is assumed by the most senior member of first response service on the scene. Options once reinforcements arrive, so they can continue to be in command or transfer command to someone of higher rank. So arrive at the scene and establish incident command. This isn't always done in EMS, but I think it's a good practice. Do a quick walkthrough of the scene to assess the number of patients, hazards, and degree of entrapment if there's any. Get as calm and composed as possible to radio in an initial scene report and call for additional resources. This is not your emergency, it is your emergency to manage. Communications. On arrival, give a brief report and request any necessary resource. Have face-to-face conversations among command staff whenever possible. Incident command is the only person to converse with the communication center, should be, and they disseminate information to others. So if we have something to say, we give it to command, command communicates that. If command needs to be notified of something that we need to know, they will disperse that information to us. Organization. Early and aggressive organization is vital. Have a plan to deploy resources. Think big and order big. It's much better to have too many people coming at you and then having to cancel them versus you don't request enough people and you need more and you're not getting them until it's too late. Think about supply and staging areas. Prevent freelancing. That's where incident command structure really comes into play. And then it's a good idea to have some kind of personal tool such as a tactical worksheet, even a notepad, something that may be above and beyond what you have on the ambulance to keep track of everything. So the senior person on the first arriving EMS will assume incident command, will oversee medical aspects and all safety of all personnel, will designate area supervisors, work with fire and police commanders, keep uninjured people from becoming injured, and restrict access to the scene. Psychological first aid may be necessary on MCIs. We're not going to attempt to engage in psychoanalysis or anything, but this patient may see things that they've never seen before and may need some psychological help. So caring and honest demeanor can reassure a patient. And emergency responders are also subject to emotional stress. Stress debriefing counselors should be available. And if we have an emotionally incapacitated EMT, they should be treated as a patient. So EMS branch functions. So the EMS branch of the incident command system, we could be responsible for extrication, a staging area, the triage and treatment and transportation areas for sure, and rehabilitation area. So triage. The goal of this is to afford the greatest number of people the greatest chance of survival, given the equipment and personnel available. The most knowledgeable EMS provider typically becomes the triage supervisor. So primary triage, we have priority 1. This is a treatable life-threatening illness or injury. Priority 2, it is serious but not life-threatening. And priority 3, which is walking wounded. Priority 4, sometimes called priority 0, they are dead or fatally injured. We'll go through a couple different triage things here. So the START triage, which stands for Simple Triage and Rapid Treatment. It's a foundation of system is speed, simplicity, and consistency of application. So it's simple commands to patients. So a patient evaluation is based on RPM, which is respiration, pulse, and mental status. So are they able to walk? If they are yes, it's priority 3. If no, we check the respirations. Only 3 treatments should be provided during START triage. You can open the airway and insert an OPA, apply pressure to bleeding, and elevate an extremity. I would argue that if they're bleeding profusely, a triage would suffice. That will take you less time than doing the pressure and elevation. Assess respiration, so breathing status first. If it is yes and more than 30 a minute, it's priority 1. If it's yes and less than 30 a minute, we're going to check a pulse. If they are not breathing, we can position the airway and recheck respirations. If they're not breathing and attempts to open the airway do not start breathing, they are a priority 4 or priority 0 patient. So we assess a radial pulse second. If they're unresponsive, not breathing, no pulse, that is a priority 4. If they are breathing with no radial pulse, that is a priority 1. If they are breathing with a pulse, good skin signs, and cap refill, we'll check their mental status. If they're alert, they're priority 2. If they're altered, they are priority 1. So now retriage the priority 3 walking patients. Same thing, RPM. And we'll go through a lot of this. We'll go through something I feel like is a little simpler. It's another unified triage process. Again, I believe it's simpler. We're going to go through a lot of this triage stuff in class and have some fun with it. So there's a color code with the triage tag with the priority patients. So a priority 1 patient is a red, a priority 2 is a yellow, a priority 3 is a green, and a priority 4 is black. Here we are, the SALT. SALT triage is what we utilize at my agency. I feel like it's a lot easier. It is sort, assess, do any life-saving intervention, and then treatment and transport. So immediate, still, that's a red patient. Severe injuries who are likely to survive with treatment. Does the patient have a peripheral pulse? Is the patient not in respiratory distress? Is the hemorrhage controlled? Does the patient follow commands or make purposeful movement? Any no answer is tagged as immediate. Move immediate patients to the casualty collection point first. Again, we're going to make this make a lot more sense in person in class. A delayed, which is a yellow tag. They have serious injuries but are not tagged as immediate. Does the patient have a peripheral pulse? Is the patient not in respiratory distress? Is hemorrhage controlled? Does the patient follow commands or make purposeful movement? Yes to all with a significant injury is tagged as delayed. Minimal, a green tag, that's a patient with minor injuries. And then dead, a black tag, that's injuries incompatible with life or without spontaneous respirations. Is an adult patient not breathing after the EMT opens the airway? Is a child patient not breathing after the EMT opens the airway and gives 2 breaths? If the answer is yes, tag dead and remain in place. Again, this is a black tag. And expectant, sometimes it's a color code gray, sometimes it's still a black tag. So they are unlikely to survive given the available resources. These are what I like to think of as the black tags that we're not giving up on yet. We just don't have the resources, and we will have to wait to reassess them after our priority patients have been moved. And we'll talk about secondary triage here in a little bit, but we're going to be reevaluating these patients throughout the time that they are in the treatment area or in the triage area. These patients receive treatment only after immediate patients have been moved forward. Secondary triage is performed at a patient collection point or triage area. These patients are separated into treatment groups based on their priority level. Each treatment area should have its own treatment supervisor. It may be necessary to recategorize a patient whose condition has deteriorated or improved. So you may have a patient who has had an immediate tag, they've been red tagged due to respiratory distress that was fixed or made better before they were able to be transported. That patient can now be moved to a yellow tagged patient if it calls for it. And you may have a walking wounded who walked to the triage area that now has respiratory distress and needs to be moved to a red tag patient. So this is a constantly moving assessment. So we need to make sure that we're reassessing every patient that's in our triage area. Transportation and staging logistics. Once the patient is assessed, triaged, and treated, patients are transported according to priority. The staging area is where ambulances wait for patients. A staging supervisor keeps track of ambulance vehicles and personnel. Transportation supervisor arranges transport of patients from the scene to the hospital. Overwhelming a hospital's surge capacity could bring poor outcomes. So, we have 2 trauma centers. This may be something, depending on the size of the incident, that we're bringing helicopters in to help fly them to Wichita or Oklahoma City and disperse these patients a little bit so that we're not bringing, 6 priority 1 or red tagged patients to one trauma center who cannot handle that kind of a patient surge. Communicating with the hospitals, receiving facilities need to be contacted early to determine capabilities and update on expected patient counts. We may only have 3 patients that are red tagged that need to go to a hospital. Where I'm at, St. John's is the closest trauma center. They have 2 beds in their trauma bay. They also are working with other people. So if another service is bringing in a patient with severe trauma from whatever else, they're already taking up 1 bed. They may not be able to take my 3 trauma patients. So we still need to contact these facilities early and determine what they have, what they are capable of in the moment. The transportation officer, not the individual EMTs, should be the ones communicating that. In these large-scale incidents, normally have a big turnout of people that get plugged into this incident command structure. Generally, there's too many patients to allow a good radio report, so kind of give more basic information to free up radio traffic for other people bringing in other patients. All right. If you are the first rescue vehicle to reach the scene of an MCI, what should you do? So obviously we need to assess for safety, do a scene size up, determine whether or not we need to establish a command system, request additional resources and all that. So maintain a high index of suspicion and awareness. Many hazmat incidents start out as routine EMS calls. The biggest problem in most hazmat incidents is identifying the offending substance. So we need to look for the shipping placard and the SDS, use the ERG to help determine your initial actions. Be aware that the shipping placard and records may not be correct. Remember that the hot zone, warm zone, cold zone, remember what all functions are being done in each one of those zones. Once you realize it's a hazmat incident, get to the cold zone and call for help. Keep responders in rehab until they are rested and hydrated and their vital signs return to normal. You should have a rehabilitation protocol with your local fire departments. Patients who have been decontaminated almost always still have some amount of contamination. Patients being transported must be cared for by competent EMS responders with operations level training and equipment. Use your MCI plan and procedure at small incidents, as this will make managing larger ones easier. NIMS and incident management are the national standard for incident management. Learn and practice whatever triage, mnemonic, or model that you utilize in your system. Practice it often. This is not something where large-scale MCI, unified command, all these things, that's not something that we run day to day. That is a high-risk, low-frequency event. This needs to be practiced often, practiced well. Be alert for signs of stress after incidents and seek help as necessary. Mental health in this career field has definitely been brought to light. It is way less taboo now to seek mental help. We're subject to a lot of things. So if you're not doing well, you need to be looking for signs of stress and everything after an incident in your own self, but also in the people around you. All right, remember, a hazardous material response requires specialized training and resources. Common responsibilities of initial responders must be identification of the incident, scene control, and activation of appropriate resources. Scene safety is the highest priority. When possible, use scene clues, product information, and specific resources to identify hazardous materials. Decontamination prevents the spread of a hazardous material. EMTs are commonly involved in various levels of this process. Multiple casualty incidents overwhelm resources of responding units. When this occurs, organization is the most important priority. NIMS and its incident command system provide organization, resources, and structure to provide management of large-scale incidents. Triage allows EMTs to prioritize care and transport of patients when resources are limited. Some questions to consider. What is the hazardous substance and what risk does it pose? Again, if we can identify this placard or the safety data sheet, we can look at the emergency response guide and figure out what risk it poses and our hot zone, all that. If a patient has some contamination, can we safely start decontamination? That should be started when a safe area is designated and trained personnel are present. And should I start using triage tags? Triage tags can be utilized in any size incident for patient identification. All right. Your call is to a motor vehicle collision with unknown number of injuries. As your unit approaches the scene, you see that 3 cars and downed wires are involved. You get a whiff of gasoline as you pass by. So on arrival to our scene, we need to be paying attention to where everything's located. Where are the downed wires? Do we know where the gasoline is coming from? Are we going to rush into this scene right now? Or are we going to request additional resources? Let the fire department know that there's fuel, there's fluid on the ground, there are downed wires. We need to get personnel in here with the equipment and training that we don't have. The drivers are visible in each vehicle. One appears to be conscious and the other 2 are bent forward or slumped back. There are passengers visible in 2 vehicles, one or more of whom may need extrication. How should you proceed? So early recognition of hazmat incident ensures personnel safety and allows for early notification of necessary resources. So we should use all of our senses when we're doing a scene size up, look, smell, all that. Notify the appropriate personnel, the appropriate agency, and get them there to do what they know how to do with the equipment that they have that we don't. All right. Thank you very much for your time.